Well, hello, everyone. It's Elizabeth Morosco with Kudos Magazine. I am incredibly excited. I have a chance to sit down with an incredibly talented and knowledgeable physician who's able to help women and families finally connect with their dream and having children. And this is specifically tied to people that are having a difficult time, being able to get to the point of getting to birth, whether it's through health problems that you have, diabetes, high blood pressure, so many things. And today he's going to share some insight with you so that you can understand new things that are happening in medicine and treatments that are available right here in mid-Michigan. You are listening to the Cup of Kudos show, focused on healthy, happy living with little antidotes of wisdom, inspiration, and sometimes a little spunk.
Yeah, hi, Dr. Robert Welch. I take care of high-risk pregnancies, which is a wide range of things. It's related to management of everything from prenatal genetics to management of high-risk pregnancies to diabetes, hypertension, what I call bread and butter maternal fetal medicine.
With patients that would end up finally getting to you, how would that come about? Are they referred or do they specifically seek you out?
It's a combination of things. I'm referred a lot of patients. So the general obstetrician or midwife is seeing a patient in their office. They recognize that they've developed some type of complication, be it onset of diabetes, their blood pressure is going up, or they've had a previous history of diabetes or hypertension. Or while we're doing ultrasounds, we do a lot of prenatal ultrasound and prenatal diagnosis. We may see some abnormality in the baby, which requires us to talk to the parents as well.
The case of women that have diabetes that happens during pregnancy where they can be normal blood sugar level, and then there's some, I don't know what the percentage is, I think I read around 7%. That can get into complications like that. What would be some of the telltale signs that, hey, maybe this is something more than just not feeling good and being pregnant?
Well, pregnancy is a stress test for the woman's body. So things that could come out later in her life tend to occur during the pregnancy, early on. Now, they'll go away after the pregnancy and then maybe come back later in life as well. But diabetes is a classic example.
I never knew that.
Yeah, so but somewhere between 7 and 15% of women develop some form of diabetes in pregnancy, and it's actually kind of dangerous, predominantly for the developing fetus, because it can get excessively large. It can die as a result of high blood sugars. As it comes through the pelvis, because it's so large, it gets entrapped, and it causes damage to the mother as well, because then she has bladder incontinence and other types of complications later in life.
I have never heard that those can become telltale signs of something later on that can come up with your health. Okay.
Yeah, somewhere around 50% of women who develop diabetes in pregnancy develop diabetes later in life, called maturity onset diabetes.
No kidding. Yeah, I've never heard of that, so I learned something new today.
Well, what we do is we advocate that they, after the pregnancy is over, they stay in contact with their family practitioner or a midwife for the rest of their life and get annual exams, because they could tip over into diabetes, and that's why they need continuing health care.
So with some families that are maybe pre-exposed to different genetic conditions, do you guys offer genetic counseling? And
we do genetic counseling and genetic testing. So let's say a family has a history of hemophilia. We can, first of all, by ultrasound, we can usually tell if it's a male fetus, because male fetuses tend to be affected. But we can do genetic testing as well. So that's either by something called chorionic villus sampling, or CVS, which is done usually up to around 12 weeks in the pregnancy, maybe up to 14, and then amniocentesis, which is done after 15 weeks in the pregnancy. So it depends on when the patient comes in terms of what procedure we'll offer, and some other technical issues as well. But things like Down syndrome, for example, we can make prenatal diagnosis of. We may see ultrasound abnormalities that tell us there's some kind of syndrome there. And we need to get the most information we can about the pregnancy so the pediatricians have the right experts available when the baby's born.
So what are some of the tests that you do? Would that be like the 3D ultrasound and blood and
from a prenatal diagnosis perspective, we in the ultrasound side, we can do 3D or 4D ultrasound as well. 4D is 3D in motion, basically. But that's usually, that's surface rendering. We can see things like cleft lip and palate that way.
Wow.
Most ultrasound is 2D. It's still the best approach. So most laboratories have it. But this is different ultrasound than ultrasound that's being done in your routine physician's office. This is ultrasound done by highly skilled sonographers, backed up by a reading maternal fetal medicine specialist, so that we can see things that aren't seen in a routine exam. Then the other tests that we do are really biochemical and molecular tests. Mm-hmm. So we're taking fluid or we're taking samples of tissue from the placenta. Mm-hmm. Those are going out to a special laboratory where they can actually form a chromosome map called a karyotype, or they can do something called microarray, where they actually go into each individual chromosome and they can determine its function and what types of proteins it's producing.
It's incredible. It's incredible. Some of those words I don't even know, but I guess it comes to the benefit of having medical expertise like yourself.
Well, it's changed a lot over the last 30 years. We've gone from getting basic chromosomes to, as I said, this microarray technology that really allows us to get down to the microdeletions and duplications in individual chromosomes. So it gives us a lot more information about the baby before it's born.
Mm-hmm. So how many babies would you say that you've delivered over the course of your career?
I think around 5,000. Yeah.
It's like a small village.
Yeah. I guess it is, yeah. Because I did a very comprehensive residency program, delivered probably 500 or 600 babies before I had graduated my residency program. Then I did a maternal fetal medicine fellowship and delivered babies through that. And then I had a practice in maternal fetal medicine, so I used to deliver a lot of diabetics and hypertensives and other complicated pregnancies. And over the years, it grew. And now I'm not doing deliveries anymore. I'm doing consultation. I feel like more of like a coach. I send in the plays, right, and let the team carry out the play.
Sometimes that's where the best expertise can be, so that you can teach other people.
Right, exactly.
The way,
yeah, yeah. I wouldn't want to practice anywhere without a residency program, because residents are valuable. Mm-hmm. I think a lot of
you have a residency program here at Hurley.
We do, okay. And I think that a lot of lay people look at residency programs like, oh, that's a junior doctor. Well, it is a junior doctor, but they're being supervised by senior doctors. So right. I look at it as a large practice. Mm-hmm. You have junior partners and senior partners. Mm-hmm. And so as long as the senior partners are keeping track of things, the junior partners do just fine. And it works out really well.
And I think that's how we actually groom our future leaders in any industry, is being able to have the experts train them with the wisdom they have, and then exposed to new knowledge, exactly. New technology.
And they keep us up to date as well. They're doing things and new trends, and we're doing research with them, et cetera. So it works out pretty nicely.
Your specialty, it requires additional schooling, correct?
Correct. It's
not just like a regular doctor. You're like an extraordinary special
doctor.
To
be an OBGYN, the OBGYNs do 4 years of residency. Right. To be a maternal fetal, you do that 4 years, and then you add on 3 more years focusing on high-risk pregnancies.
So just when you thought getting your doctorate degree, PhD was...
MD, yeah.
Oh, an MD, yeah. Wrong doctorate degree. Just as soon as you think an MD,
they think they're the real doctors.
Time. Yeah. But nonetheless, that's pretty amazing. So in another 3 years on top of those 4 years, so it's like a couple decades of school. So I'm sitting next to somebody that's obviously really competent with 5,000 babies in 20 years.
One of the nice things about when you go to school, so to speak, when you're a resident, you're actually a practicing physician. You're licensed by the state of Michigan, and you're getting paid a salary. So at least you're making an income so you can survive. Mm-hmm. So it's not like you're paying tuition to go through a residency or a fellowship. I know there's been some discussion of that in the past, but it would be almost impossible, because you're in your 30s by the time you complete your training. So it's a long time.
So what advice would you have? This is kind of on a sidebar note, but for people that are looking at possibly getting into the medical field to be a doctor or to go into this, I mean, what advice would you have for them?
Well, first of all, I love what I do. So certainly OBGYN is hot. What's very interesting is when I started practice, or started my training actually, I applied to 3 programs for my residency. Today, they're applying to 30 to 35 programs.
Oh my goodness.
And the reason for that is because of a big change in medical education. Now we have more than 50% of students in medical schools are women, and women want to do women's health. So they're all applying to residency programs in obstetrics and gynecology.
How many women would you say were in the program when you went through?
Well, in my program, we had 11 residents, and I think 3 or 4 were women. in the program, but per year.
Right.
So
they were cutting edge.
They were cutting edge, and of course it's continued to grow. And now most programs are more than 50% women in the program. In fact, some programs are almost exclusively women in the program.
Really?
So it's really changed a lot. Yeah. But it's made it much more competitive then too, because you've got all these people focused on this one specialty, so it makes it hard to get in. And of course it's raised the bar tremendously.
So maybe those PhDs at the university are doing something right to get the women into the program.
They must be. That could be. Yeah, that could be.
Yeah, that's wonderful.
Yeah.
But getting back to women's health, one of the things that I think is important, and a lot of people don't know it, is Hurley's arrangement with departments like yourself, and then having the right staff here after delivery to handle these high-risk births.
Yeah, we have the continuum of care. We can take care of patients who come in, first of all, with just routine births, which we're very good at. And we have both midwives and attending physicians who take care of routine pregnancies. And they have the backup then of the neonatal intensive care unit should something go wrong. But then also for these high-risk pregnancies, we have the neonatal intensive care unit. So if we have somebody who presents with preterm labor and preterm birth, we have the neonatologist right here. The baby doesn't have to be transferred somewhere, or it doesn't have to go far away, and the mother has to try to go back and forth to see that their child in the nursery. So they're here at the same time. I
had heard even with babies that may have cardiac problems that you'll have a cardiac doctor here.
Well, we have, yes, and first of all, prenatally, we do a lot of our own fetal echoes within our unit, but we also invite in a cardiologist out of University of Michigan who comes twice a month. And so we select down the cases that are the most complicated for her to see. So she then determines whether they can deliver here or have to go down to the University of Michigan. So you
work with collaboration. So it's you guys are looking very closely at all the factors. I love that.
Yeah,
it's really able to give, I think, patients a sense of security, because when you are going through a high-risk pregnancy like that, it's very stressful. And knowing you have all these hands on deck, it sounds like you've got every base covered.
Yeah, it's well coordinated. That's the key thing. Because once again, we're trying to find out everything we can about the baby as a fetus, and then we have that information to give the neonatologist when the baby's born, so they just pick up from there and continue on.
Mm-hmm. So is there any insight that you'd like to give to words of hope for women and families that have been trying to have a family and where we're at today?
Well, you don't have to be pregnant to get a consultation from maternal fetal medicine. You know, if you have something where you've had a previous loss, or you have recurrent pregnancy loss, you have complications with preterm birth, or other types of medical or surgical complications that could complicate the pregnancy, we'd like to see you before you get pregnant if possible, and look over your information, get your medical history, and then we can make recommendations in terms of what medications you might want to take earlier in the pregnancy. There are certain blood pressure medicines, for example, that you shouldn't take in pregnancy, and others that you should. And so some various interventions that we can do. And sometimes even with diabetics, we have controlled their sugars better. Endocrinologists do a great job with controlling blood sugars, but we tend to control them even tighter during pregnancy, because we know that birth defects occur early in the pregnancy from diabetes. So we want to control it.
No kidding. I did not know that. I feel like I'm getting a lot of lessons
thrown
at me. This is good.
Yeah, the background rate of birth defects is about 2 to 3% of pregnancies. So things like cleft lip and palate, those types of things. For a diabetic who's on insulin, it could be somewhere around 6 to 8% if her sugars are not well controlled. So it basically doubles or triples.
Yeah. Those are some crazy numbers. But having people like you look on board,
we think we can help there.
That's wonderful. Gives a lot of hope, especially for people that have gone through struggle, to let them know medicine is evolving, care for women is continuing to grow in a positive way to make those dreams a reality. I'm really grateful for all the time that you've put into communities to help make those dreams a reality, because just in one given day, that birth can literally change the life of a family, and you have something to do with that. So I think a big fat kudos to you, Dr. Welch.
Well, thank you. I think I've saved lives.
I love that. And I believe that to be true. Yeah. So thank you for taking the time to meet with us. And if you want more information, you can go to Hurley's website, I believe it's hurleymedicalcenter.com. And we look forward to hearing any feedback. In the meantime, if you have a chance, make sure that you give us a great big kudos by sharing this video and podcast. All right, you guys, in the meantime, have a beautiful day. Thanks.